The topic for today's discussion is undifferentiated and mixed connective tissue diseases, which is chapter 53 of the Rooks textbook of dermatology. First of all, you should have the concept of the UCTD or MCTD. This is more or less the same thing, only the difference is the presence of antibodies in MCTD patients. As the name indicates, if the patient has clinical or serological and pathological features of any connective tissue disease, but it's not fulfilling the diagnostic criteria for that typical disease, the patient will be classified as having UCTD patients. There is a chance that over time the patient will develop additional sign and symptom of any typical disease fulfilling the criteria, and that will fill into the typical connective tissue disease like RA or systemic sclerosis or SLE or dermatomyositis polymyositis. So the diseases that are included in the UCTD, which is undifferentiated connective tissue category, you can remember it by a simple mnemonic SPSS, which is SLE, polymyositis, dermatomyositis, SSS for systemic sclerosis. Additional is RA. So these are the diseases that are included in the UCTD. For MCTD, as already described, there is additional feature of the UNRNP. Rest of the things are same as UCTD. If we talk about epidemiology, there is a female to male ratio of 3.3 to 1. So there is increased prevalence of UCTD or MCTD in a female patient as in the case of any other connective tissue disease. For the pathophysiology, there are some genetic factors or there are some environmental factors that are triggering for the disease. The most important is the UV radiation. UV radiation plays an important role in the MCTD patient. So there is a photosensitivity in all the patients of the mixed connective tissue or undifferentiated connective tissue disease. Second thing is the body's response. Body has autoreactive T and B cells that is causing immune system activation. So there will be defective immunity in the patients of the MCTD. Third important thing is hypertrophy and the proliferation of small and medium sized blood vessels causing the Raynaud phenomena. So mostly in patients of MCTD you will find the Raynaud phenomena. So if the patient of SLE or any other connective tissue disease is having Raynaud's phenomena, you can classify or you can make your second differential as Raynaud phenomena. Not Raynaud, it's MCTD. Fourth thing is that in the patient of MCTD, there is increased level of endostatin. Endostatin is basically the inhibitor of angiogenesis. When there is inhibition of angiogenesis, there will be increased risk of digital ulceration due to compromised blood supply and the poor healing. So in the patients of increased level of endostatin, there is a useful marker for the risk of increased ulceration. This is a simple method pathogenesis. UVB triggers cellular injury, which is causing UNRNP to be activated. It binds to the U1's small nucleolar ribonucleoprotein 70 kilodalton motif, and there is cellular apoptosis. This is all the summary of the pathogenesis of the MCTD patients. There are some genetic factors which play a role that are not so important in these cases. The next important thing is due to photosensitivity, these patients avoid sunlight and there is gross deficiency of vitamin D as well. Vitamin D is very important for the immunity of the patients. So when there will be deficiency of the vitamin D, there is going to be immunosuppressed state. So that is further aggravating your autoimmunity. And another important trigger is TNF inhibitor or vinyl chloride and silica. This can be remembered by the mnemonic that the patient is having photosensitivity, he is not going outdoor and sitting indoor and watching TV and having snacks. So TV and snacks in the form of MCTD patient, T for TNF inhibitor, V for vinyl chloride, and S for silica, snacks for silica. Okay, let's talk about the clinical features of the UCTD and MCTD patient. These are more or less same. UCTD, let's say a patient is having a isolated Raynaud phenomena and the patient is also having the serology which is positive and the nail fold capillary examination is abnormal, but no other definitive symptom or sign of the connective tissue diseases that is fulfilling the criteria. So patient will be classified as having UCTD. Another thing is that patient may have the positive serology or skin biopsy for a specific connective tissue disease, but the rash that the patient is having is very non-specific or not fulfilling the diagnostic criteria. So again, the patient will be classified as UCTD. Raynaud is a common feature in the UCTD. This is very important. Even with the Raynaud, you will find the abnormal nail fold capillary in the form of capillary loops or the hemorrhage, irregular vessels, or the capillary dropouts. If we talk about the prognosis of the UCTD, one third of the UCTD patients subsequently meet the diagnostic criteria for the defined CTD in the near future by developing one or more additional clinical or lab findings. And the 10% will have remission, will be developed clinical remission. The risk of disease progression appear higher during the first 2 year of onset. In MCTD is more or less same for the UCTD, that the patient is not fulfilling the criteria or having the overlapping feature with any other disease, so we just differentiate, just put the patient into the MCTD criteria. Okay, there are some criteria, diagnostic criteria for the MCTD. One is very important, which is Alarcon-Segovia criteria. For the patient to be labeled as MCTD, the most important thing is patient should have U1RNP. So all the criteria of MCTD will have serology of U1RNP must thing. The titers differ. In Alarcon-Segovia criteria, titers are 1 is to 1600, while in Kahan's criteria, it's 1 is to 1200. These are the must thing. First is criteria. The second thing is clinical. Clinical can be remembered by the mnemonic that the Alarcon sends a rude SMS. So Alarcon, for remembering the Alarcon criteria, he sends a rude SMS. A for acrosclerosis, root for Raynaud phenomena, which is a must thing or common thing, not a must thing, it's a common thing in MCTD. SMS for synovitis, myositis, and swollen hands. So by remembering this one line, you can just compile your criteria. A, a root SMS is acrosclerosis, Raynaud phenomena, sinusitis, myositis, and swollen hands. There should be serology positive and the three clinical signs in which the myositis or sinusitis is a must thing. So this is Alarcon-Segovia criteria. Kahan's criteria is more or less same as Alarcon-Segovia criteria, but the difference is that there is swollen hands in the Alarcon-Segovia criteria, but there is a swollen fingers in the Kahan's criteria. So there is swollen fingers, sinusitis, myositis, Raynaud phenomena. These are the same thing. Acrosclerosis is not present in the Kahan's criteria. And the must thing is also change. In the case of Alarcon, it was myositis and sinusitis. In the Kahan's, it's just Raynaud phenomena. So Raynaud phenomena should be present in the Kahan's criteria to be fulfilled and remaining two clinical features. Okay, another important criteria that are for MCTD is Sharp criteria, as the second name of MCTD, and Kasukawa criteria. For investigation of patient with the MCTD, the first important thing is antibody profile. You should rule out all the connective tissue diseases or suspected connective tissue diseases, and a must thing which is UNRNP for fulfill the diagnostic criteria of the MCTD. Then, keeping in mind the connective tissue diseases, you have to do the Rho and La antibody, SCL antibodies, double-stranded DNA, RA factor, anticardiolipin, lupus anticoagulant, and Jo antibodies for all the connective tissue that are forming the four parts of the MCTD criteria, that were systemic sclerosis, SLE, dermatomyositis, polymyositis, and RA. Apart from antibodies, you can also do the immunofluorescence, which is the presence of basement membrane staining with immunoglobulin IgG or IgM, support the diagnosis of MCTD when trying to distinguish from the systemic sclerosis. So it is an important clue as well. For the comorbid condition, you have to remember for other tests that can be done to rule out the organ complication, that are pulmonary function test, DLCO, or the transthoracic echocardiography, brain natriuretic peptide, urine analysis, blood pressure, and the electrocardiogram. There will be low-grade anemia and the hypergammaglobulinemia. Management is same as the other connective tissue diseases. You have to avoid the triggers like sunlight or smoking cessation. You have to deal with the inflammatory lesions like pleurisy, arthritis, pericarditis. For the active inflammatory lesions, you can give corticosteroid in the form of 0.5 to 1 milligram per kg, or in the case of Raynaud's phenomena, just give the symptomatic treatment or the pharmacological treatment of the Raynaud's as well, like calcium channel blockers, phosphodiesterase inhibitor, prostacyclin analog, iloprost, endothelin receptor blocker in the form of bosentan. If you find a patient with SLE or any other inflammatory disorder, HCQ can be given, or methotrexate can be given as an immunomodulatory drug. And for the refractory cases, rituximab is the option. So this is all